Scott Jensen here. Today I want to talk about an odd topic. I want to talk about autopsies. I want to talk about the declining rate of autopsies related to a potential sloppiness in the medical field. I believe that over the last 3 years of the COVID pandemic, there's been concern that perhaps we haven't been as aggressive as we could have been in terms of trying to learn more. And this really came to a head just in the last few days. I've seen several patients, and death certificates and autopsies have come up as questions. So let's start with death certificates. I had a patient in the other day whose mom had died in her 90s, and I asked what she died of because she was not a patient of mine, and she had died of congestive heart failure. So I asked the patient, what do you feel was the initiating event that sort of started her mother's decline? And she said, well, I don't know, but I think in the hospital they talked about her cause of death would just be congestive heart failure. And I said, okay. But I said, can you think of anything else? And she said, well, mom really seemed to start to turn downwards when she experienced atrial fibrillation. And with atrial fibrillation, she had a fast rhythm and she got into trouble. And when I got done talking with this patient, I thought, gee, I wonder what that death certificate looked like. Did it say that the underlying cause of death was congestive heart failure and leave it at that? Did it identify the atrial fibrillation, which from the family, or at least this daughter's perspective, might well have been the initiating event? Would that be the underlying cause of death, which led to potentially decreased cardiac function or congestive heart failure, which may have led to a respiratory failure in the hospital causing the death? I think it's really important to remember what the CDC and the Vital Statistics Department in the United States asks physicians to do regarding death certificates. It says this in the CDC guidelines. It says the underlying cause of death should be reported on the lowest line in Part 1. And it should be the disease or injury which initiated the train of morbid events leading directly to the death, or the circumstances of the accident or violence which produced the fatal injury. But I think the important thing is the initiating event that started this process of demise. This is where I think we've gone wrong. I think during COVID pandemic, I've been outspoken on the fact that we've had at times the underlying cause of death identified as COVID when the COVID diagnosis may have been an add-on because of a positive test on intake through the emergency room. It may well have been that there was an injury or an accidental catastrophe of some sort that really initiated the event whereby the patient died. And the positive COVID test may have been a contributing cause or may not have been. But I think this was an issue for many doctors and nurses and ER personnel, as well as ICU personnel across the nation. I had another patient recently pass away, and I got the hospital discharge, and I was looking at it, and it said that the cause of death was a respiratory failure. Well, that's very possibly true, that the immediate cause of death was a respiratory failure. But I think when I think back to taking care of this patient through his last 30 years or whatever, for me as a physician, now I was not completing this death certificate because the patient died in the hospital. And so typically, even though I'm the primary care doctor, hospital personnel will take care of the death certificate. But I would say that in this given situation, that this patient, his cancer that I diagnosed a couple of years ago was clearly the initiating event, which led him to be very frail, developed subsequent kidney failure, diabetes, weight loss, and recurrent pneumonia. And then in the end of his life, on a hospital bed, respiratory failure culminated in his immediate cause of death. But the important cause of death would be the underlying cause of death, which in this patient's situation would have been his cancer, because that's what could affect generations to come, and that was what was the initiating event. So let's shift gears now and talk a little bit about autopsies. I've read numerous articles recently about the decline of the autopsy. I read an article today written by John Leake, L-E-A-K-E, June 13th today, and it's under the Courageous Discourse Substack of Dr. Peter McCullough. And the title of the article was Concealing the Cause and Manner of Death. And in this article, Mr. Leake comments on his own long-standing interest in forensic medicine, and then goes on to define forensic medicine as the branch of medicine devoted to determining the cause and manner of death. And I would elaborate on that definition and say the branch of medicine devoted to determining the cause and manner of death and or injury. That's forensic medicine. So I did a little looking, and I came across an article written by Ben White, and this was on March 2nd, 2021, under Brief Policy Perspectives. And it commented on the dying American autopsy. I think the play on words is intentional. And says this: the rate of autopsies has drastically declined. I can testify to that. I went into medicine in the 1970s. And in 1970, approximately 50% of in-hospital deaths would result in an autopsy. Autopsies served as an important quality assurance tool, and not only were they valuable for teaching and training new doctors, they served to highlight the disparities between doctor diagnoses and the actual causes of death. In the British Medical Journal, there was an article, I believe from 2021, from one study that used autopsies, and it indicated that as many as 40,500 Americans die in intensive care units each year with misdiagnoses. Now, I don't know about that exactly. That's a lot. 40,500 in America, that would be almost 1,000 per state if it was divided equally by the 50 states, which is not likely. But regardless, in a state like Minnesota, that would indicate that we would have something like nearly 1,000 deaths in intensive care units with misdiagnoses. You might say, well, does it really matter? Well, I would say the next sentence in this article is really critical. When genetic diseases are in play, a proper diagnosis of the cause of death, the underlying cause of death, can be critical to ensuring surviving family members at high risk of the same diseases are aware of available preventive medical options. America's sinking autopsy rates have done no favors to healthcare providers in our efforts to promote preventative medicine. Going from a rate of 50% of in-hospital deaths having autopsies in 1970 to current data, which shows that in recent years, less than 5% of hospital deaths are followed up with an autopsy. We have to ask ourselves, are we as aggressive and ambitious as we have been in the past regarding learning? During the COVID pandemic, I think this was absolutely critical. I would ask several questions. I would say in the early months, when we saw so many people dying of respiratory immediate causes of death, particularly on the East Coast with the very aggressive and ambitious use of ventilators, would more autopsies have demonstrated data that would have allowed us to realize sooner that simply increasing the pressure that was being utilized to push air into the lungs wasn't doing our patients any good, but in fact was potentially increasing the death rate, the fatality rate on a ventilator from 30 to 35%, which was the norm prior to COVID, up to 80% in some areas during the COVID pandemic. I'm asking the question, are we as aggressive and ambitious and determined as we've been in the past to learn as much as we can? If we're not, why is that? During the COVID pandemic, I think that there's a lot to be learned. I think that if we've got myocarditis related to COVID disease, we should be doing everything we can to figure out why does COVID-19 cause myocarditis. If we've got myocarditis in the realm or the time sequence or the time frame of 30 to 90 days within a COVID vaccine, we should be doing autopsies and comparing that myocarditis with the myocarditis patients that died from COVID disease and not from the COVID vaccine. We have to look at the amount of spike protein that was deposited, where it was deposited. Did it cause clots in the coronary artery, or did it seem to compromise the muscle function? Were there large areas of the electrical system or the heart wiped out? It just seems to me that after 40 years in medicine, I ask myself, the declining rate of autopsies intersecting with arguably, for me, in my opinion, this is just my opinion, but arguably we're seeing a declining number of autopsies intersect with a COVID pandemic where we've had more disagreement among physicians, among public health leaders, among policy leaders. And it seems like, I would ask, is this where we want to be? And then I go back to my patients that I mentioned a few moments ago. One whose mom died a while back, and she wasn't sure what the death certificate would say. I encouraged her to make sure that she did get a chance to see the death certificate. I also reflect on my patient who recently died in a hospital and was identified as dying of respiratory failure. Now, I'm hopeful that the death certificate, because I have not seen that death certificate, and typically I would not be given that opportunity. It's possible, I suppose, that I could push for it and see if I could get a hold of it, because I am the primary care doctor. I could certainly work through the family. But nevertheless, from my perspective, I'm hoping that that death certificate indeed identifies the underlying cause of death as the cancer that initiated the train of events that led to my patient's death. Certainly there were many in-between steps from the initiating event to the immediate cause of death. But I really am beginning to wonder, how are we going to change this? I don't see a lot of robust discussion on the part of physicians to move forward with being more aggressive about learning. I think we're missing things. I think we missed things during the COVID pandemic, and I think I did too. But I think we're not as aggressive about how can we learn. I had many patients come to me whose loved ones had died, and they requested autopsies and were refused. The only way they could get an autopsy done was if the patient and family were willing to pay for it. Autopsies can come in a variety of procedures. You can do a complete autopsy. You can do a partial autopsy. And I'm not going to go into the detail on that. But I think it may be necessary for all of us, outside of the realm of doctors and hospitals, perhaps in the realm of everyday living, where we might need to start pushing a little harder and saying, we're not certain what our loved one died of, and we'd like to get as much information as we can for the generations to come and to see if there was something that we could have done better. I think that's what's made medicine as skilled a profession as it is. Obviously, I'm trying to be careful and not offend anybody's sensibilities, but autopsies teach. And if we're not doing autopsies, I have to ask the question, is our appetite for learning as robust as it should be? It may be that you and I need to start pushing in order to maximize our collective skill as patients and doctors in being healthier. Have a good day.